Assalamu alaikum. My name is Dr. Salman Alsafran. I'm an endocrine surgeon. I'm assistant professor at Kuwait University. I'm the chief of endocrine surgery at Jabir Al-Ahmed Hospital. It's my pleasure to be here with you today. I'm very glad to visit Iraq for the first time in my life. And I'm stunned with the hospitality and the kindness of the people here. We'll just wait for the presentation. Since we have time, let me tell you what happened to me. I arrived to the airport. My bag didn't arrive, so I didn't have anything to wear. So last night, after we finished dinner, this is how kind people were. They took me to a shop at 11 o'clock p.m. They bought me those clothes. Yeah, you know, and then they didn't let me pay for it. So, you know. All right, okay. So we're going to talk about retrosternal goiter and advanced management. As we all endocrine surgeons, we very frequently encounter those big thyroids. Let's see. All right, I have nothing to disclose. All right, so when we talk about the retrosternal goiter, the definition, there has been multiple definitions in the literature. Some people would say descending below the thoracic inlet. Some authors would promote when more than 50% of the thyroid, it's within the thoracic, below the thoracic inlet. And some would say when it's below the fourth vertebra. However, simply, when you have a goiter that's going into the mediastinum that requires you to do some dissection to be able to extract or deliver this thyroid from the mediastinum. It was first described by Dr. Haller in 1749. Its incidence between 2 to 45%, depending on which series you looked at in the literature for the total thyroidectomy. It's most common in the sixth decade of life. Female tend to be more with 3 to 1 percentage. Dr. Klein was the first surgeon to perform retrosternal goiter excision. Yes. Huh? What's that? Huh? Oh, sorry. I'm just having issues with this. So they're actually divided in two different types. It could be a primary or a congenital. And that part, when you have, basically it's called isolated mediastinal goiter, which basically there is no connection of the goiter in the mediastinum to the thyroid in the neck. And very important to know that blood supply of this kind of goiter comes from the vessel within the thorax. Trying to attempt to deliver this thyroid through the neck without knowing the blood supply could basically lead into tremendous bleeding. And luckily, this is the least common. It only represents 1% of all the mediastinal goiter. The more common one, which are the secondary, they are acquired. You have a thyroid in the neck that basically grows down to your either anterior or the posterior mediastinum. It's attached to the thyroid, and it shares the same blood supply of the thyroid. This classification was adapted from a book by Dr. Randolph, dividing the mediastinal goiter, could be either to the anterior mediastinal or the posterior mediastinum. And then when it's in the mediastinum, could be a crossing, which is the type 2B and 2A and 2B, and the primary one, which is the type 3. So when it comes to symptom, majority of those goiter are actually discovered incidentally with patient getting worked up for other reason or getting scans for other diseases. Sometimes they will present with the neck mass, dysphagia, shortness of breath, or sleep disturbances. Majority of those patients, they are euthyroid. About 10 to 20% of them would have hyperthyroid or hypothyroidism. And truly, there's about 25% of them are completely asymptomatic, which brings a dilemma. What should we do with those patients who are completely asymptomatic? So when we talk about the management of those retrosternal goiter, obviously surgery is the way to go. And why would we recommend surgery for those patients? We know the nature of the goiter is a progressive disease. It's going to grow with time. And as it's grow, it's probably going to become symptomatic eventually. And we don't want to wait for those goiter to be so large to go and do the surgery. And that surgery is going to be complicated, which will require us to do transthoracic approach, which we're going to talk about in the next few slides. It also will help when the patient is asymptomatic. We'll treat the patient's symptom and avoid unexpected large growth of the thyroid, which occasionally some patient will come within a month, they have a large goiter, and now you have to remove it. Imagine if this is within the mediastinum. And nowadays, with advances in surgeries, and we are becoming more and more specialized, and the morbidity and the mortality with this kind of surgery is very low, especially when you go to a high volume experienced surgeon. We can do it very safely, and most of those cases are done through a transcervical approach. The other thing is sometimes when there is a malignancy, it's very hard to be able to obtain biopsy from those thyroid goiter. When we look at the alternative, there is absolutely no alternative. And multiple studies have looked at using radio iodine ablation or hormonal therapy with very modest effect. So even in asymptomatic, it's been agreed upon that surgery is the way to go. When it comes to the investigation, we'll do the investigation as any thyroid. In addition, the most important and the most valuable imaging, I believe, is the CT scan. I'm sure most of you guys believe the CT scan. CT scan will be able to assess how inferior is the goiter. You will see where its origin, and then also you will be able to assess the trachea. MRI, it has its uses when you want to rule out invasion into the trachea. However, it's not cost effective, it's claustrophobic, and associated with a lot of artifacts. So, as I mentioned earlier, although surgical management is agreed upon, the indication for transthoracic approach remain controversial. What I mean by transthoracic is either doing partial or complete sternotomy, doing minimal invasive. Nowadays we do minimal invasive. We go through a VATS, mobilize the thyroid in the chest, and then through a transcervical incision, we will be able to pull it. And that's very helpful for recurrent goiter in the mediastinum. And when you have an isolated posterior mediastinal goiter, sometimes the best option is to go the posterior lateral thoracotomy. When you go to an experienced and high volume surgeon, the rate of needing to go through a transthoracic approach only between 2 to 8%. Some of the literature, they could go up to 30%. So what are the indications for transthoracic approach? As I mentioned, very rarely used. I've used it only once. I'm not as experienced as most of the surgeons here, but I've only used it once for a huge goiter. But when you have a malignancy within the mediastinum, the only way to be able to deliver this malignancy and do the proper lymph node dissection is to basically open the chest. When you have a posterior mediastinal goiter, the problem with the posterior mediastinal goiter, the nerve is actually ventral. Normally, when we deliver it, the nerve is posterior. When it's a posterior mediastinum, the nerve is always anterior, and it's becoming very challenging to deliver them. In that case, you probably need to revert to your transthoracic approach with isolated mediastinal goiter or the primary mediastinal goiter needed. And when you have a huge goiter, that you will not be able to deliver it through the thoracic inlets, which means the goiter is actually bigger than the thoracic inlet. Sometimes you have to revert to transthoracic approach, or intraoperatively, when you try to deliver it, you get into a massive bleeding, then there's no other choice but to open the chest. Operative consideration, I mean, you guys, most of the speaker ahead of me spoke about the techniques and the best way to do the things. There's nothing changed about doing the retrosternal goiter. Things to point, one of the most important thing is to try to identify the nerve as early as possible and do not do the delivery or extraction through the mediastinum until you actually identify the nerve. It's very helpful when you try to pull it. Try to go, there's always a capsule or a tissue attached to the thyroid. Close to the thyroid, tries to divide them sequentially as you pull your thyroid out. And you'll be surprised. I'll show you some of the cases. Mostly we were able to get them through the transcervical approach. Other tricks, when you have big goiter, you can do the contralateral side to give you some room to be able to mobilize the trachea and be able to get the thyroid out. And taking the upper pole early also helps. I think that's basically some of the tips. And very important, plan it well. Do not go to the operating room without having a backup. Get thoracic surgeon involved. Get a senior member or get a member you trust with you. They are most of the time are simple, but when things go down, when they go downhill, you have not enough time to react. So this is some of the cases that I've encountered during my time. So this is a 64 years old female with more than 20 years of toxic multinodular goiter. Her endocrinologist was very reluctant for her to have surgery. She came to us with basically, gasping for breath. She wouldn't be able to lie flat. We did the scan, and this video will show you the thyroid. I would probably ask some of you here, I mean, do you think this will come through the neck? No? All right, okay. Anyway, so I'll show you the picture. So it's very interesting. We're able to actually just able to pull it through the neck completely. And what's interesting here, we didn't even have to rupture the capsule. We didn't have to do anything. Looking at the thoracic inlet, this is actually was larger than the thoracic inlet, and we were able to pull the thyroid out. Ready for next case? All right, so this is a 48 years old female who was worked up for asthma with shortness of breath. She had the complete workup, everything was negative. Eventually she got to see an endocrinologist who decided to do a CT scan. He did a CT scan, and I'll show you the CT scan in a minute. She had a big goiter from the left side, crossing behind the trachea and the esophagus, going all the way down to the carina on the right side. We do a vocal cord assessment. The left vocal cord is paralyzed. And this is the video. I included one cross-sectional image.
2 minutes.
And just have a look.
2 minutes.
All right. Do you think this will come out? All right. Anybody will do something different than lobectomy, given that she has a nerve injury and the biopsy is negative? Benign? Yeah, we're almost done. Yeah. All right, okay. All right, so we were able actually to do it through transcervical approach. It was challenging to pull it out. Some of the capsule ruptured, that's why we were able to pull it out, and you can see very small scar. Patient went home within a few days. She was off all her medications. Case number 3, 54 years old, female with multinodular goiter, severe compressive symptom. And I'll show you the CT scan. This is actually very impressive. All right. Sternotomy, no sternotomy? Sternotomy? All right. No sternotomy. All right. Again, I was prepped. I have the thoracic surgeon with me in the room. We were about to do it, and then just came out. And this is the last case. This is a male patient, which actually did him last Sunday, just before I traveled on Monday night. 52 years old, multinodular goiter, compressive symptom. Just look at the size of this thyroid. Sternotomy, no sternotomy? Okay, you guys believe in me. Thank you. Anyways, so this is actually the thyroid. It's actually almost 900 gram. It's almost like, yeah. And we were able to do it through only trans-cervical approach. So in summary, retrosternal goiter should be managed surgically. CT scan is the most valuable imaging or investigation. Thoracic approach for retrosternal goiter, rarely needed. Trans-thoracic approach for the mediastinum, either partial sternotomy, full sternotomy, minimal VATS, or through the posterior lateral thoracotomy. Again, I can't emphasize this is more. I mean, MDT, have somebody with you. When things go down, they go very quickly. You could lose the patient. With this, I would thank you and thank you again for the opportunity. Looking forward to meet you all again.